This is More to Say with Randy Naughton. Interesting conversations with interesting people. We welcome you into another edition of More to Say with Randy Naughton. It's my podcast, and you've been listening and watching all over all of the places that you get your podcast, wherever you stream it, Spotify, Apple, YouTube, you name it. It's everywhere. And of course, I'm all over social media as well. I would love a follow. I'd love for you to keep up with what we're talking about. Basically, what we want to do is have interesting conversations with interesting people. And based on your response, I think we're accomplishing our goals, because we're sort of kind of all over the place. As long as it's informative and interesting, I think it's worthy. So, and today is no exception. Today's episode, and I was a little bit nervous about calling it this because she's a serious doctor. I'm calling it Boobies, and I don't even care that I sound like I'm 12. But that's what we're calling it, mainly to get people's attention and to talk about everything boobies, breasts. Please welcome Dr. Theresa Schwartz, formerly of St. Louis, SLU Care breast surgeon. She now works at the Henry Ford Center in Detroit. Doctor, so nice to see you again.
Yes, you as well. Thanks so much for having me.
Well, I remember our talks when we were on TV together. You were always so incredibly informative, whether it was about certain research or new test studies, things like that, or anything that had to do with breast cancer and the newest information. And we definitely want to touch base on that for sure. Now, let's talk about breast cancer. I know that it is one of the, I remember the statistics, 1 in 8 women get breast cancer. Does that still stand? Have there been any improvements there?
No, that still stands. 1 in 8 women are being diagnosed with breast cancer every year. And as we screen more and as we're looking more, it seems like the numbers go higher, but it's not the case. We're not any different now in terms of statistics than we were a few years ago. So all we can do is keep up our good screening regimens.
Yeah. So are we? I mean, I know there's mobile mammography vans. There are regular screenings, where you're going into underserved neighborhoods. People are coming to you. Are women taking this seriously? Are more and more getting their screenings?
Yeah, it depends on the area, depends on also the awareness. That's why anything like this, or anytime there's a celebrity in the news, like first time I was actually on TV with you was whenever Angelina Jolie came out for having preventative or prophylactic mastectomies. So any of those events that kind of bring breast awareness, breast cancer into the mainstream media or social media, it ends up bringing more people out to get screens. So anything that we can do on the medical side, like you mentioned, mobile vans, or trying to make more rural areas available, that's what we've got to do. No one wants to drive 2 hours to get a mammogram. No one wants to have to go to the city to get a mammogram. So whatever we can do to make it more available is what we, honest to God, have to do.
And we talk about celebrities who often come out into the forefront. Others keep it private. And of course, that's their business. Well, you mentioned celebrities like Angelina Jolie, one of the first times we talked about it, how she had preventative double mastectomy because she was carrying the BRCA gene? She was carrying the BRCA gene. How does that help? And did you see a surge in your office of more people wanting screenings and more people ending up doing that very thing?
The one thing it really did was push people to have a more frank discussion with their family members about cancer risk, because a lot of times, like how you just said, hey, this podcast name might rub people the wrong way or be different, because no one wants to talk about breast at Thanksgiving. No one wants to ask what uncle had prostate cancer, or what great grandma passed away from. It usually just gets hushed. And the one thing, whenever celebrities come forward, especially with something like Angelina Jolie, it was saying, well, I don't know what my family members' cancers have been. I don't know if that puts me at a higher risk. And it kind of pushes them to go talk about it with their doctors. So yes, in terms of getting screening, it helped a lot, but it really helped just the awareness of what the rest of the people you're related to, or what your environment looks like, to know what your risk personally is. Because I can tell you 1 in 8 all day, but if it's you, it's 1 out of 1. So, you got to know, hey, which side am I on, and until you know your risk factors, you really don't know where you fit.
Wow. That's quite the attention grabber, what you just said right there. 1 out of 1. That's you.
Yeah.
Why is it so taboo?
I don't know. I don't know why we do that it's something we can't talk about, either breast or cervical cancer, ovarian cancer, anything gynecological, or anything from like the men's side of things in terms of prostate cancer. It's like it just can't be discussed. But, also I think a couple generations ago, most people were very private about any medical issues, and it wasn't something that was discussed, especially if things didn't go well. The conversation just ended. And I think we're getting out of that realm, but you have to keep pushing it so that you know what your family actually had.
Yeah, and I love more and more people with all the genetic and the genealogy sites and things are all kind of learning more about what is in their family, what runs in the family, things like that. So it can only be a good thing, in my opinion. So let's talk about mammograms. We talk about, I don't know. I don't even know when it was, but it was like, okay, the FDA says this is when you're supposed to get your first mammogram and do it every year. But then they lowered the age, then they raised the age, and then they came out with different guidelines. I'm sorry. I mean, I get mine every year, no doubt,
Mhm.
easily. It's on my calendar every year. That's just me. A lot of women don't. And a lot of people say, well, I had a appointment, but I canceled it because new information came out that said I don't need it. What is it as we sit today, the recommendation?
What's great about the timing of this podcast, honestly, is that just a couple of weeks ago, the United States Preventative Services Task Force issued a new set of guidelines because that was the big change a few years ago. They were the first group to say, at 40, you can decide if you need to do this, but maybe we do this every year at 50. And then once you get to 65, do it every other year. And it got everyone confused because there
Yeah.
were other societies that had completely different guidelines and nothing matched. So now the United States Preventative Services Task Force just issued another recommendation. Now, this is for women of average risk. So you'd have to know your family history. You'd have to know if you are at average risk to start mammograms at 40 and do it every year. So, like, huge change. Now it matches what all of us who treat breast cancer, it matches what we would actually recommend. So it a big difference. So now there shouldn't be as much confusion. Although there are a lot of people that no matter what recommendations we have, it's still not a test they're really excited to go get.
No.
So making sure we continue to remind them, because it's not something you're like, God, I can't wait to get in there. The
No.
continuing to remind them about the importance of it and making sure that things aren't missed or delayed too long. That's the only way we're going to get people to actually follow guidelines that say come in every year.
Yeah, well, let's not forget the fact that there are some people, some women who end up getting breast cancer in their 20s, in their early 30s, and they're like, I never had a breast exam before. I never had a mammogram before. So this is where self-exam comes in. And there are little placards in every doctor's office that show you how to do it in the privacy of your home, in your shower. What are the guidelines for that now? When should people
Right.
start doing that?
In terms of just kind of being aware of yourself, it's really tough for that structured self exam to be easily repeatable. Because even if you try and do it the same time around your menstrual cycle or the same day every month and try to make sure that the breast should be about the same, density or irritation or whatever different feeling it has every month, that's tough to do. And I mean, in 15 years, I guess, of doing this, I mean, I can think of a couple of people only that actually noticed something doing a structured self exam. It's
Oh, wow.
always by accident, always like I was putting on lotion or the dog jumped near me or the seatbelt didn't fit right. But if you notice something, then it's like, all right, now I need to pay attention to what's going on.
Yeah.
So it's not ignoring those things because you're going to end up examining yourself without even realizing you're doing it on a daily basis. But it's just not ignoring it if something changes. And then just, I mean, really paying attention to how you look even in the mirror, making sure that there aren't any differences there.
The symmetry, any lumps, any things like that that you can see.
Yeah, skin changes, anything that if there's reddening or thickening or changes to the nipple, just stuff that you're like, well, that wasn't there a couple weeks ago. Because even if you're seeing your regular doctor and getting a breast exam once a year, that's a really hard thing to remember. Like, hey, did the nipple really look like this a year ago?
Yeah.
There's no way that they would know the consistency in your exam, but you will. So it's paying attention to those little subtle changes and just making sure you don't ignore something that's an abrupt difference.
Let's go back to mammography and mammograms here for a moment. Like you said, it's not pleasant for those who don't know, who may have never had mammogram before. They literally squish your breast between these two big cold plastic plates and take photos of it from each angle. Let's talk about, are there things such as false positives? And how do dense breasts come into play regarding the readings of mammography?
The breast density, I'm thankful it's been part of the conversation. It has been a new piece of information since about 2015. whenever it ended up being a law state by state, of course, but saying, hey, you got to tell patients how dense their breasts are on mammogram. Mainly so they know, all right, my mammogram is transparent. They'll be able to pick up things pretty easily. Or my mammogram is pretty darn dense. And so I need to pay attention. Even if my mammogram is negative, if my exam is telling me something, I can't ignore it. But the breast density question is something that still hasn't been answered, because about 40% of women who get mammograms are in the more denser last two categories. So it's not like it's exceedingly rare. I mean, you're talking 40% of women are going to be in that dense category. So are there other screening modalities we can use? And man, it gets tough because there are other things. I mean, there's breast ultrasound, there's breast MRI, but they're not as good as mammogram in terms of picking up what actually matters. Unfortunately, both of those tests have a lot of false positives. Like screening breast ultrasound, I think it's over 90% of the things they call abnormal aren't abnormal. So it picks up a whole lot of stuff that really probably shouldn't be picked up. It's all benign, but causes a heck of a lot of worry, anxiety, maybe additional tests, but also like extra cost, extra days off work.
Right.
So we got to figure out a way to balance that better. And right now we don't have a good answer for it. Density is still a big question. 3D mammograms help a lot because now you can actually scroll through the mammogram at 1 millimeter cuts instead of it just being one picture. So hopefully little differences will be picked up, but there's not a single test on the market that'll ever be perfect. That's for sure.
Yeah. And as far as picking up those images and things like that, if you're good 1 year and you go, oh, I'm good, I'll let it go for a couple of years. Is that your recommendation, or do you want it every year?
No. Every year. Honestly, it's easier for the radiologist to compare year to year. You can tell subtle changes year to year. But 2 years is a really long time. And especially in a younger age group where the breast density might not change as much, trying to pick up something that's subtly different. You wait a few years, it could be a completely different mammogram, and you're kind of comparing apples to oranges. So absolutely every year is what I would recommend. So there's really no reason, unless it's impossible to get to postpone it to more than that.
I'm a huge proponent of self-care and health maintenance and preventative care, and I make all my appointments around the same time every year. So that's just me. I think everybody should. Let's talk right now about mastectomy. You talked about Angelina Jolie. She had a double breast amputation, mastectomy, as a preventative measure, but a lot of women need to have their breasts taken off, so just to remove the cancer. How has that advanced over the years before? And I won't say it's not traumatic for a woman, because I'm sure it is. I've known people who have had that procedure and, shown me the scars, and it's a wow kind of a thing. Have there been many advancements in not only the procedure, but the recovery of that, the physical recovery as well as the psychological recovery for women?
Yeah, I think a lot of it depends on what you're doing the mastectomy for. So for instance, someone who's doing it for preventative reasons, I have a really long conversation with them up front about, okay, what would happen if the cosmetic outcome of this wasn't great, or if the implants you got failed, or if something went wrong, a bad infection, lots of pain, would that be okay? Because the reason for the operation is to help reduce your risk of breast cancer, but you have to know, hey, my cosmetic outcome may not be great once this is done. And if you're doing it for preventative reasons, that's a lot harder to accept sometimes than if you had a cancer and knew that it needed to happen. So trying to make sure your mindset from the beginning and all expectations from the beginning are appropriate, and you've got all the right information, hugely important, because it's not like going in for a breast augmentation where it's your breast just bigger. It's a completely different chest wall. I mean, it feels different, looks different. It's all brand new to you no matter what. From a oh, sorry, go ahead.
No, I was just going to ask, has technology kind of advanced to kind of make that process easier for women?
The one thing that's really great are the options for breast reconstruction now, because, not that long ago, really the only options that we had were breast implants. And a couple of them have even come off the market, or how they look on one chest wall versus another can be completely different. So now, depending on how a woman's body is shaped, there's times they can even use fatty tissue from her abdomen and then rotate that up, and then they don't even have implants, because there are some patients that flat out can't get implants. So there's different ways that, based on how that individual person, how their body looks, we can change up the reconstruction to hopefully get them the cosmetic outcome they want. because like you said, this is a traumatic procedure.
Yeah.
So trying to get them back to a state of normalcy, that's tough. So you got to make sure we've set expectations from the beginning, but also given them all available options so that the right one for them can be chosen. But yeah, we've made a lot of strides on the reconstructive side, that's for sure.
That's pretty amazing. And I do want to pivot to that. And I know this is not your specialty. We're going to talk about enhancements, and women are getting boob jobs and getting implants and getting them bigger, getting them smaller, getting them taken out. Um, you know, I know this isn't what you do on a day-to-day basis, but is there a better implant than others? Because there were some that were recalled from the market, some that burst inside the body. What is, like, I guess, the best one to do right now?
Yeah, the ones that were recalled, they actually had a really good like in theory, outcome because they were the kind that couldn't have ruptured, and everybody was really excited about them. But then there was it's very small, but it's not zero risk of having an implant-associated lymphoma. So pretty traumatic
Wow.
to get a breast augmentation and end up with a lymphoma and no implants after the fact. So those implants have been off the market since I think late 2019. But the other ones, it really depends on how that person's chest wall is, because now honestly the plastic surgeons have to go shopping in the hallway to say, all right, I need one that sits up higher here or has more projection this way. But it's all based on how that person's chest wall is. So there are so many options to be able to fit it to your specific chest wall. Now, going saline or silicone, I don't think there's much of a difference there. All of them, I mean, it's a plastic, piece that doesn't belong to you. They all have a chance of rupture.
Right.
I think any of those companies probably wouldn't give them a shelf life of more than 10 years, like that they could guarantee. They could be fine forever. You could have trouble with them within 10 years. But going saline or silicone wouldn't make a difference necessarily, as long as it's the right one that fits your chest wall.
Now I've heard this before. Breast implants give you breast cancer. Breast implants help prevent breast cancer. Either one of those true?
Nope. Nope. As long as you're still getting your mammogram. I've had people think the implants would keep you from being able to detect a breast cancer, and
Hmm.
that's not true. If you go to I'd go to a more reputable breast center that maybe does patients with implants a lot if I was getting this, but they do extra views to take looks around the implant since it's not just a straight shot through. But it doesn't do anything to increase your risk. It doesn't make it harder for a good radiologist to read your mammogram. So they're plenty safe as long as you're going to the right place to get screened.
Now we're going to talk about breast reduction. I actually consulted with you a number of years ago, asking for recommendations for doctors for somebody I know who has unnaturally very large breasts, causing them problems. What is the procedure there? Should you go to your primary first? Should you just go straight to a reconstructive place? Does insurance cover it? Does it cause other medical issues? You tell me.
Yeah, I don't know that you would need a referral to see most plastic surgeons for this, especially if it was someone who does a lot of breast reconstruction and breast reductions. But going to see a plastic surgeon, honestly, who does a lot of breast reductions is the way to go. And I mean, without a question, the patients who get breast reductions are the happiest postoperative patients. It is, I mean, most of them are like, I don't even care about scars. I don't care if my nipple didn't make it on this side. Like the reduction is just such a game changer, because most of the time it's like, as you said, why is this so taboo? If you have large breasts, you have felt self-conscious about that from the day that you realized how much bigger you were than anyone else, or the day someone else pointed out how much bigger you were than everyone else. And just being able to sit up straight or feel comfortable in your own clothes, huge difference. The
Now,
recovery for it is no joke. It's
yeah,
a
tell me
big
about it.
operation. Yeah, so most of the time they'll end up having a very big incision that goes all along the bottom of the breast, and sometimes even going up the center, like at the lower half, like the 6 o'clock position. But all that breast tissue underneath, a large portion is taken out, and the rest of it is more swung around, and then put so it's more lifted, a lot of skin removed. So it is a decent recovery, probably 4 to 6 weeks worth of not doing your regular physical activities. So it's nothing that should be done it's not a weekend job, that's for sure.
Well, there are a lot of people I know who have had the procedure, and like you said, they are so happy they've done it. They're grateful they did it. They feel better in clothes. Obviously, the scale is different. They look better. They have more confidence. To me, I mean, and does insurance generally pay for it, or do you have to kind of prove that you have medical issues associated with it?
It's more proving that the breasts are a problem of some sort. And of course, as we all know, every medical insurance and whichever policy you have is slightly different. But most of these women have pretty substantial lower neck, upper back pain, divots, like to where you can see them dug into their shoulders from their bra, even hyperpigmentation where this is dark from being beat up so much. Or even having bad rashes or wounds underneath their breast if they're that large. So it's kind of putting everything, all the pieces of the puzzle that make it problematic. And then a lot of plastic surgeons will also have to somewhat guess how much breast tissue is going to come out, because some insurance companies will cover it if it's X amount of grams that would be removed, others only if it's Y amount of grams.
Really?
So, oh yeah. So like maybe if it's too small, they say it's not necessary. So the plastic surgeons have to jump through a lot of hoops, but it's absolutely doable, and really it should be. I consider it a medical problem for sure. People have a whole lot of trouble when their breasts are too large.
Wow, and you should know. All right, well that's it for all of my questions, but I want to ask you, doctor, if you want to leave our listeners, our viewers with any particular advice about anything, mammogram screenings, you name it, and then where they go to do this.
Yeah, I think the biggest thing, honestly, was just even doing things like this. It's getting the awareness where people are actually talking about it and not considering this something that's private that you only discuss with your gynecologist if you've got 5 minutes at the end of a visit. So it's number one, making sure you know your family history, asking those questions that nobody really wants to talk about, to know who has what age they were when they got it, what kind of treatments they got. Sometimes that even requires digging through some paperwork to find out for real what cancer something was, instead of just the game of telephone. And then making sure that information gets passed along to whoever you see regularly. And a lot of younger women aren't seeing a regular primary care doctor that often. They're seeing their gynecologist that often. So those are the ones to say, hey, here's my family history. Do I have anything I need to be doing more of? And then running risk assessments to see, all right, where do you fall? Are you considered average risk? Are you considered high risk? Is there something else we need to be talking about, even in women under the age of 40 who otherwise wouldn't be getting mammograms? Maybe they would qualify for it. So if you know your family history and you're willing to talk to your doctor about it, and then be open to whatever is recommended, and knowing, all right, let me weigh risks and benefits, like how I mentioned breast MRI and breast ultrasound. Those are tough. You have to know you might be flipping a coin to come back for extra tests, and what would that do to your psyche and time and money, and all the things that can kind of go into it that we tend to not pay attention to up front. But it's not being afraid to talk about it, not being afraid to ask questions to the family, and then be able to pass that along to your doctor, and then get the information back to know what's best for you. Because those stats, I mean, those are stats. They're great for people like me whenever I'm looking at an entire population of women, but it's really hard to know where you fall personally.
Yeah, that one thing you said, every 1 in every 8 women get it, but if it's you, it's 1 in 1. So that's when you pay attention. So you've been a wealth of information. I appreciate it. This has been Dr. Theresa Schwartz. She is a breast surgeon out of the Henry Ford Cancer Institute out of Detroit. She's a Lions fan. I'll give this Bills fan will forgive her. See, I've got Buffalo Bills stuff behind me. So I'll forgive you for that. But anyway, I appreciate your time today. You've been a great insight into some really important information, and we really appreciate it.
You are very welcome. Thanks so much for having me. I'd be happy to come back anytime.
Oh, and I might call on you, Doc. Thank you.
Okay.
And for everybody listening and watching, please feel free to share, like, subscribe, follow me on all the social media channels. This has been More to Say with Randy Naughton. Thanks for joining us.
This is More to Say with Randy Naughton. Interesting conversations with interesting people.